TopMedTalk.
Welcome to TopMedTalk. This week we revisit one of the most popular moments from our coverage of Anesthesiology 2022. This conversation is a real highlight. This piece begins with Desiree Chappell, Monty, Mythen and Sol Aronson speaking with their guest, a well-known name here on TopMedTalk, Lee Fleisher, who they'll now introduce.
Tremendous pleasure as a friend and a colleague to introduce Professor Emeritus Lee Fleisher. Lee,
Yes.
so good to see you.
It is a pleasure.
Yeah.
It is a pleasure. My current role is as Chief Medical Officer and the Director of the Center for Clinical Standards and Quality at the Centers for Medicare and Medicaid Services. But I'm here as you say, Emeritus Professor of Anesthesiology.
Lee, you have been a giant in the world of anesthesia for so many years. Talk about, your role whenever you were at Penn and some of the things that you did there, because we've had many conversations with you over the years to highlight that, but I really want to make sure people hear some of those things.
So 17 years as chair.
Mm-hmm.
And, one of the things that I think is incredibly important, I know Sol did that at when you were at Duke particularly, but it's very important that anesthesiology be very engaged in how the entire health system worked. So besides being the chair of anesthesiology and mentoring young people and worrying about the educational and the research programs, and I did a lot of collaborative research, I was chair of the malpractice committee. I was co-chair of the managed care contracting committee. So I did a lot of the negotiations with Blue Cross Blue Shield and Aetna, and I think those were important. I know you did a lot of negotiations in that role, because if we're not at the table,
You're left behind.
we're left behind. We'll be eating for lunch.
On the plate.
On the plate, that's right.
Absolutely, because most people don't understand how anesthesiology works as far as payment.
Unfortunately, true.
And they don't understand that we can't be tied to Medicare. That, in fact, it's really important. So being there in the table, talking about the other services was critically important. And we really do, both in my current role and at Penn, we really do understand a little bit about everything in medicine.
Yeah.
We understand because of our pain clinics, outpatient services. We understand how hospitals work. We have to know a lot of medicine. We know OB. I've been involved in the federal government in some OB work. And when they said, why do you fit? And I'm like, well, I was chair of the medical board, but I also was an OB anesthesiologist when I was at Hopkins. So we really do understand medicine, surgery, obstetrics, and anesthesia.
Yeah, it's a very holistic, for sure.
Yes.
And I would add even population health.
I would agree.
I would agree. And yes, I know I still talk about that paper you wrote with a good colleague, Mark McClellan, and it really does show, and particularly in my current role, we're talking a lot about social determinants of health. And when Karen Domino yesterday talked about equity, our pre-op clinics and a lot of what we do, we can lean into food insecurity, transportation, and what Monty's been doing.
Professor Monty Mythen, everyone.
Welcome. Sorry to be late, team. Has taught us for decades. So I think it's really interesting as I see both my federal role and my previous role, how we're interacting.
You also just very, very briefly did a lot of work in partnering with multidisciplinary specialties, when it comes to society and societal and anthropological type things. Just really briefly kind of go through some of those, because I find that so fascinating.
Well, before I came into the government during the early time of the pandemic, how to address the emotional contagion of what our intensivists felt, of going into the ICU, and how if we didn't break that cycle, we wouldn't be able to do our job. There was no vaccine. So I actually worked with an organizational psychologist to help me understand the anxiety and what are the factors to be able as a chair to say it's okay and not let the negative emotional contagion. I hired a linguistic anthropologist. We had done a lot of work in a couple things. One is informed consent. We all talk about shared decision-making, but a lot of patients don't have that educational knowledge. You and I can do shared decision-making, but a lot of them say, hey, doc, what would you do?
Escalating authority.
Absolutely, yes. That's okay. We just need to understand how to do it best, and how a lot of the decisions that we think the surgeon has really started way upstream. And that's
Right.
what our anthropologist said really starts in talking to your neighbors and going to the medical clinic. So by the time you get to the surgeon, there's already sort of an anchoring on what they're going to do.
The work you did, which I've seen presented a couple of times now, that you just referred to with regards to COVID stressors, is there a plan, or have you repeated that? Because we're kind of assuming that a lot of those stressors might have gone away, or maybe they've changed and got worse in some things.
I haven't done that work because I'm mainly doing health services
You've been
work.
busy.
So I've been busy. It's been very interesting to watch the healthcare system from my vantage point. It was fascinating what happened when so many people in the U.S., I don't know in the U.K., but I believe it's different but similar, didn't take the vaccine. And what happened was the exasperation,
Yes.
the anger of providers taking care of people who could have been less sick if they just took the vaccine, took over. And we've been spending a lot of time thinking about, in this post-pandemic world, we've got burnout for so many reasons. But I think that's one of them, and I'd be curious.
How does that translate to the patient who smokes, or the patient who doesn't manage their diet well? There are analogies there, aren't there? And how do we use those lessons from COVID going forward?
It's very interesting because we have to acknowledge that we're in privileged positions and we believe in the science. But there's a lot of people, and we can't forget about Tuskegee and the distrust of the system. And you got leaders in American medicine and getting up there and saying, this is the solution to COVID. And then there's all these examples of how they were wrong. And it's anecdotal examples. And what we learned is those anecdotes totally discounted because we as scientists don't know how to, in our minds, we talk about the idea, we know all the caveats and all the limitations from our papers, but we don't speak that way. We also, and this I learned from others, we say they were wrong, as opposed to they made a good decision for themselves at the beginning, but can we provide them with more information? And I've learned this from the organizational psychologist who taught me emotional contagion. So we really have to understand that there's a lot of, what I'm learning, social determinants that have caused a lot of these problems. And the way we articulate it is not helping the problem.
It's a really, really good lesson for those of us who are so immersed in the scientific process of a means of communication. But there's a medical anthropology that I think we are a bit remiss in teaching ourselves as we evolve up our, educational journey.
It was fascinating. I've had communication specialists come in. I just had from the UK, Stephen Rolnick, who does motivational interviewing. He's from Cardiff, who keeps teaching me different ways of thinking. He actually said, you should say, you're a smoker. This was more about COVID. Can I have permission to talk to you about that and not just start talking at them?
Oh my gosh.
Right.
And I'm like,
That is a game changer.
this was game changing for me because, in fact, people talk about translation.
Yeah.
And we have a very large in the U.S. Hispanic population. And they talk about, well, you could just get your iPad out and you can translate. And I kept hearing from the Secretary of Health, I got to figure out how to do cultural and language appropriate services. I'm saying, well, we got translators.
Well, not the same.
And he goes, my father, born in the U.S., only spoke Spanish, very poor English. And when he went to the doctor, he wouldn't tell about his diseases. So even if you sort of spoke Spanish or used a translator, you didn't get to what he needed to do to understand the cultural background of how he talks to doctors. That was the game changer
Light
to me.
bulb.
Yeah, ding, ding, ding.
I can't do that for him, nor will I ever do that for him. I got to find a provider who can.
Yeah. Wow. That is a light bulb moment.
The culture of medicine.
Yeah. We don't have a ton of time. There are a couple more things I wanted to talk to you about. One is maternal mortality and care of maternal
Pregnant
patients.
people.
Yes, pregnant people. What's changing? What needs to change?
We know now that there's such structural racism that my administrator, Princeton grad, said even she, who's highly educated, huge job, is that people like her have higher mortality and morbidity when they go through labor and delivery. You probably heard IVF. There is structural racism in the way we treat black women, people of color in this country for maternal mortality. And I finally said, Sal, when you were at Duke, and I never asked anybody to look based upon race, the incidence of epidurals, pain management, time to C-section. We said, we treated everyone the same. But do we know it?
I cannot answer that with data. I only can answer that with my presumptions and assumptions.
And we should start doing that as anesthesiologists. We can lean in. And then, of course, after Dodds...
For people may not know.
So the Supreme Court decision in the U.S. in which they reversed Roe v. Wade. And I can't go into a lot of detail, but, one of the things that I'm hearing in many states is that providers, and these are obstetricians, are afraid to take people to the OR when they're not truly dying because it's to protect the life of the mother. But I know you're an cardiac anesthesiologist, but back when you were a resident, could you say that a 20-weeker who came in with premature rupture of the membranes, in which you're the anesthesiologist in the OR, do you know when you actually hit that point where they have a fever? Do they have to be septic? Or if they're quite sick, they're never going to make it to do that D&C, which would result in a termination of the pregnancy, because right now it's viable.
The question of maternal morbidity, mortality predates Dodds.
Yes.
And I've always presumed, and help me if I'm incorrect here, that it was just a question of access, the equality of access. But it's deeper than that.
It's deeper than that.
Okay.
It doesn't matter if you're educated and have access. They're still seeing these differences. And now, post-Dodds, the question we as anesthesia providers who participate in these D&Cs, who all of us believe it is the right thing to do, and per the Emergency Medical Treatment and Labor Act, if a pregnant person comes in and they need to be evaluated and stabilized, there's confusion about what that is these days. And I think we as anesthesia providers need to stand up and say that we will support our obstetrical colleagues in doing the right thing for these pregnant individuals.
Yeah.
And the inequality's quite stark, isn't it? I mean, it's shocking to a certain extent. We've done a few interviews before with colleagues in the US in OB practices, and when we listen to the numbers, they're shocking.
It's shocking. If you're in Pennsylvania, no problem.
Yeah.
If you're in other states, I mean, if before Dodds we should have practiced one way, post Dodds we need to practice the same way, but I'm not convinced that's happening.
Yeah, that's interesting. Just really quickly, we have in past conversations talked a lot about the merit-based incentive programs and how that drives quality and where we're going in the future. Just briefly, what should we expect in the world of anesthesia for what's coming down the pike and kind of looking over the horizon a little bit? Because currently what we're doing, I don't think it's exactly where we need to be. It doesn't sound like.
Anesthesia took a lead in developing the MIPS value pathways, which is even if you're part of a large practice plan, which you and I were, we're not being measured on flu shots, but we're measured on anesthesia work. And that, I think, is I give the ASA a lot of credit for taking a lead and working on that. And the goal is really to get to more outcomes that matter and more shared outcomes. Because, Sal, you were foreshadowed It's all about population health. It's all about accountable care.
Well, anesthesia can take a role in flu shot compliance. You
Yeah.
know, when the patients are going down that swim lane of surgery, why shouldn't we be obliged to check their flu status?
Yeah.
Well, both of you taught us that, and all the work you did at UCL. So
The big challenge we have at the moment, Lee, I think we're all feeling is we think we know the right thing to do, and we've demonstrated the right thing to do. Now we have a challenge where we don't have enough providers to just do the anesthesia. If you see what I mean.
yes,
And I'm saying anesthesia is really, really important, but they're sort of pushing back and say, it's regressing possibly.
Yeah.
We're committed to the public health components of it. We've got to follow through and get the providers, which are going to be a much more diverse group, to be able to deliver the dream that's been described.
All right. Well, gentlemen, Lee, I hate to cut us off.
To be continued.
Because we can. I'm sorry. We have got
Always
to.
a pleasure.
It is always a pleasure, and I'm so glad we can make it work this
Thank you
morning.
for the
so thank
opportunity.
you so much.
Don't forget, of course, the links to the full unedited conversations are available in the show notes.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.